Well, thanks so much for joining me today for episode 4 of season 5 of the Healthy Skeptic MD podcast. I'm Dr. Michael Hochman. Again, thanks. Big thanks goes out to the SCAN Group and SCAN Health Plan for generously supporting the Healthy Skeptic MD. And this week, actually, congratulations are in order because the Chief Executive Officer of SCAN, Dr. Sachin Jain, is the recipient of the 2022 Champions in Health Award from the Partners in Care Foundation here in Los Angeles. A real nice honor for him. Sachin was a previous guest on the Healthy Skeptic MD, a topic titled Radical Transparency in Healthcare. If you haven't seen it, check it out. One of the most popular episodes that we've had. So today I'm going to talk about one of the areas of medicine that, at least in my opinion, has changed the most in the last 5 years, and that is the treatment of diabetes. For the first time, there are medications that meaningfully and significantly lower cardiovascular risk. And many people didn't realize that there weren't such medications before recently. I am not one to be easily impressed by new findings and new medications, but these I really think are a significant advance. And to help us understand it, my guest is Dr. Nihar Desai. He's the Associate Chief of Cardiology at the Yale School of Medicine in New Haven, Connecticut. He has many accolades and research and publications, and he's a leader at the Yale New Haven health system. But the thing that impresses me most about Nihar is his ability to clearly articulate complex topics in a way that anyone can understand, and he does that very well today. If you do find today's episode engaging, please do search and subscribe to the Healthy Skeptic MD wherever you listen to podcasts or look for my YouTube channel. And with that, let's jump into our discussion about diabetes medications with Dr. Nihar Desai. Well, I'm very happy to be joined today from Yale by Dr. Nihar Desai.
Well, thanks very much for having me, Mike.
Well, it's a real honor, Nihar. I think you know the literature about as well as anybody, and you can communicate it well. Before we begin, can you just tell us a little bit about your background and your medical training?
Yeah, sure. Happy to. So I'm trained as a cardiologist. I finished med school at the University of Connecticut and then did my training in internal medicine and cardiology at Brigham and Women's Hospital, completed a master's in public health, and actually was deeply interested in health services research and outcomes research, thinking not only about new therapies and new strategies to treat our patients, but also how do we think about patient engagement, patient empowerment, and making sure that those therapies and strategies that we have tested and have been shown to be beneficial actually get to the patients and communities that need them.
That's great. Now you're an associate professor at Yale now. You're the associate chief for cardiovascular medicine. And then you also have a more operational role, the medical director of value innovation at the Yale health system. A lot of different stuff there. So what's your day-to-day like?
Yeah, it's a great question. And, my days are full and quite fun doing, all kinds of different things. First and foremost, I'm still a practicing cardiologist. So I spend time seeing patients in our, cardiac intensive care unit or at our hospital, in New Haven, working with our fellows and trainees. The other sort of big piece of my job is I have a fair administrative, portfolio kind of overseeing a very large and complex section. We have about 170 faculty members in cardiology here at Yale, a very large and deep, research program, and a clinical service line that actually covers a very large geographic catchment area. In fact, essentially from Westchester, New York, all the way up to Westerly, Rhode Island, the Yale New Haven Health System and the Heart and Vascular Center now really covers that entire kind of geographic area. And then kind of the final area, and one that I've been quite interested in from the earliest parts of my medical training, is really thinking about value and innovation, really thinking about how we address the challenges that we face in terms of quality, access, equity, and how do we really bring those together through the delivery system and say, hey, as there continue to be rapid evolution or transformation in the way that healthcare is paid for, that has to then be connected to and linked up with the way that we're organizing care, the way that we're delivering care, where it's being delivered. And I think all those things are also being rapidly transformed. And through the work that I can do in the health system, have pretty unique ability and some insight then about how we're going to do things differently for the patients and communities that we serve.
Well, today we're mainly going to be talking about diabetes and some of the new medications, but some of those value questions are very relevant because some of these medications are very expensive. And maybe I'll come back and ask you a couple specific questions about how you balance those cost considerations with the added value of some of these new treatments. So one of the ways that I think medicine has changed the most over the last 5 years is some of these new medications that are available for treating diabetes and managing cardiovascular risk. Before we get into it, what is diabetes? Everything from differentiating type 1 versus type 2 to what causes it. Could you just give us like a very brief overview?
Yeah, the way I think about diabetes is it's essentially a disorder of elevations in blood glucose. And the two principal types, though I have to admit that as we learn more about genetics and we learn more about all the different contributors, to these two different types of diabetes, there are probably actually many different types of diabetes. But I think the two broad categories that we, sort of think about are so-called type 1 diabetes. And the issue there primarily revolves around the pancreas, that the special cells in the pancreas that develop insulin and secrete insulin are actually destroyed, and they're not able to carry out that very basic, kind of biological function. And we contrast that, I think, to type 2 diabetes, much more prevalent, more associated with obesity and metabolic syndrome, part of, I think, maybe the Western diet in many ways, and kind of not getting enough physical activity. And the disorder there is not that you don't have enough of those special cells in your pancreas, but the insulin that's produced doesn't work as well as might otherwise be. And so it's a syndrome, I would say, of what we call insulin resistance, that insulin is there, but it's not able to remove glucose from the bloodstream as efficiently as you might like to otherwise. And so both type 1 and type 2, a hallmark kind of biological or biochemical feature is an elevation in blood glucose, but there are slightly different, kind of mechanisms that kind of underlie the two different disorders.
I have to say that's one of the clearer descriptions of the physiology of diabetes. So thanks for that. I may copy a couple of those lines next time I have to describe it to a patient. So, we're going to talk about medications today, but I would be remiss if I didn't start with the lifestyle factors that affect diabetes. Fundamentally, as you described, diabetes is a metabolic condition. What is the role of eating healthy, exercise, weight loss in treating diabetes and heart complications from it?
Yeah, Mike, thanks for starting there. And I think I would just reinforce everything that you said, that we really face a pandemic now of diabetes. There's about 35, maybe 40 million Americans that have diabetes. I think just as shocking is that maybe 10 or 15% of them don't even know that they have diabetes, but actually do have it. And I would wholeheartedly agree with your sentiments that much of type 2 diabetes, especially, is at least either preventable or we can really mitigate the prevalence with lifestyle interventions. That diet and exercise and other kind of healthy behaviors, I think, can all contribute to that. And it's no surprise then, even if you look both in the U.S. and globally, that as rates of obesity have gone up, that we have seen, kind of a further rise in the rates of diabetes that have accompanied that. And so the corollary, I think, is very much true, that if we take a different approach to lifestyle, to diet, to weight loss, to exercise and physical activity, that we can have a substantial impact to reduce both the prevalence and the risk of type 2 diabetes.
So your answer triggered one clarification I want to make, that the focus of our discussion is largely going to be type 2 diabetes, the type of diabetes where your body doesn't respond appropriately to insulin and glucose. Type 1 it's about replacing the insulin. But I will say that as a primary care clinician, whenever I have a patient with new diagnosis of diabetes, what I tell them is that the treatment of it is the lifestyle change. It's the weight loss. It's the eating healthy. It's the exercise. Medications are very important, if not essential for many patients. It addresses some of the complications, reduces your risk. They're very important, but the underlying treatment is the metabolic defects, and you get at that through lifestyle change. So just because you're on a medication does not obviate the need for making those lifestyle changes. Now, diabetes is linked with a number of complications: eye disease, neuropathy, which is burning in your nerves, kidney disease. But one of the biggest is cardiovascular disease, heart attacks, strokes. Yet many of the treatments that we've had for reducing cardiovascular risk in diabetes have actually not been that effective. I think many people don't realize that insulin treatment, for example, has never convincingly been demonstrated to lower cardiovascular risk. And on the other end of things, some of the medications have even been associated with increased cardiovascular risk. There was a Vandia medication about 10 years ago that very publicly was associated with higher cardiovascular risk. What do we know about the link between diabetes and heart disease?
There's so much to unpack there, Mike. So I think a couple of important points that we have to make. So diabetes is one of those conditions that has, manifestations and involves so many end organ systems, from the eyes to the nerves to the kidneys, and then, of course, the cardiovascular system. And much of the morbidity and the mortality that's associated with diabetes actually occurs as a consequence of the development of cardiovascular disease. So we know that patients with diabetes are at much, much higher risk for heart attack and stroke and needing, angioplasties and heart bypass surgery. And so there's really been a call to action for how are we going to best reduce that risk for a large and seemingly ever-growing population of our patients with diabetes. How are we going to help them reduce their risk of cardiovascular events? I think it's also important to note that, preventing dialysis, preventing neuropathy, preventing, worsening or eye loss or vision loss, I think those are also important elements of comprehensive management of the patient with diabetes. But I think you're quite right that much of the mortality, if you will, that patients with diabetes face really does kind of stem from the development of cardiovascular disease and atherosclerosis specifically, which would manifest as kind of heart attacks and strokes and other blockages in important arteries and blood vessels.
Right. And as we'll talk about, one of the exciting things about these newer treatments is they do seem more effective at those preventing those cardiovascular complications than the standard diabetes medications. One last question before we get into the newer treatments, and that's about the role of insulin. Whenever you say the word diabetes, patients immediately think, oh man, I'm going to have to administer insulin to myself. But our thinking about the role of insulin for treating diabetes has evolved. What can you say about insulin and our latest thinking there?
Yeah, so I think you're quite right that, again, for patients with type 1 diabetes that have, kind of a loss of those cells in their pancreas, they, of course, require insulin. And that's a very important, kind of pillar of their treatment. I think for patients with type 2 diabetes, for a long time, we sort of tried to avoid the use of insulin and that we were using other things. And then I think the pendulum also swung maybe where we were too aggressive, with insulin, because there are some potential downstream consequences of having too much insulin in your body. I think we've now kind of settled on a pretty good intermediate ground, which is, hey, there are a number of oral medicines that are available. We're going to talk about some of the newer classes, but there are a number of, older, more well-established drug classes as well that we sort of use, and that we reserve insulin for the patients in whom we have an inability to attain reasonable blood glucose targets or, a range of values despite use of oral medicines. And so we sort of think about the insulins now as part of the armamentarium for managing, patients with type 2 diabetes. They're not sort of what we go to initially, but we sort of reserve them if we need them. And I think our thinking about that has kind of evolved a little bit over time. I think your point on that's well taken.
That's right. And I often will tell my patient if they have a new diagnosis of diabetes, don't be afraid of insulin, but it also doesn't necessarily need to be the first medication. We have a lot of options as well. So over the last really 5-7 years, there's been two new classes of agents, at least maybe there's a couple more, but at least the two big ones that have really changed the landscape. That's a little bit of a mouthful: SGLT2 inhibitors and GLP-1 agonists. How do these medications work?
Yeah, Mike, it's a great question. I think, and maybe before we sort of get into the acronyms, and I know it is a mouthful with SGLT2 inhibitors and GLP-1 receptor agonists. I think one other point, I think, just for the audience is, as strange as it may seem, one of the central, kind of issues that we had to confront in managing type 2 diabetes was for a disease, for a condition that was defined by elevations in blood glucose. One of the things that was really hard for us to get our arms around was the fact that in clinical trials, so in kind of these studies where some individuals were getting really aggressive control of their glucose, and in other patients were getting, maybe more liberal control of their blood glucose, there never seemed to be any differences in terms of the rates of heart attacks and strokes and the things that we were just talking about. And it was one of these central kind of challenges for the field, that for a disease that's based on elevations in glucose, that what we called tight glucose control didn't seem to lead to clinical benefits or reductions in the risk of heart attacks and strokes. And so if you look at the practice guidelines for diabetes, just from a couple of years ago, it was really a dealer's choice, kind of approach. It was really everyone should sort of be on metformin, which is a very old and kind of what everyone would agree is probably standard of care for patients with diabetes. And then there were 4 or 5 other drug classes that you could choose. And there really wasn't any guidance that one was particularly better than the other, because they all kind of lowered glucose to the same degree. But we never could really say to our patients that, hey, I'm going to recommend therapy A or B because I think that's going to help you prevent the risk of heart disease, or help you live longer, or help you reduce the risk of heart failure or other important events that we would try to reduce and mitigate the risk of. And so then I think there was a real sea change, as you kind of said, with the advent of 2 new classes. First, the SGLT2 inhibitors, and then the GLP-1 receptor agonists. I think it is worth kind of maybe spending a minute just thinking about how these 2 different classes of medicines work. So the SGLT2 inhibitors actually block glucose reabsorption in the kidney. So it essentially leads to glucose being spilled into the urine and being excreted from your body through the urine. With that, there's usually some sodium that travels with it, and obviously water that travels with both of them. And so it was essentially glucose loss or wasting in the urine. The primary mechanism then, of course, being in the kidney. The GLP-1 receptor agonists actually work a little bit differently. So GLP-1, or glucagon-like peptide 1, is a protein that's actually created by part of your small intestine. And it does a number of things. I think 2 of the most important things that it does is the GLP-1 that's in your body actually promotes the release of insulin. So that's helpful for reducing glucose levels. And then it also makes you feel full. It sort of, leads to satiety, a feeling that you are full and are not requiring any additional, nutritional intake. And so those are sort of the primary mechanisms of the SGLT2 inhibitors and the GLP-1 receptor agonists. And I think, Mike, you've rightly kind of said that there's really been a sea change now in our paradigm for managing diabetes because of some of the evidence that has emerged for these 2 different classes of medicines.
And just to second what you said before, not only was there not great evidence that the diabetes medications lowered cardiovascular risk, there's even been some associated with increased cardiovascular risk, Avandia, the overly aggressive treatment. And the teaching I always used to have was that if you want to lower cardiovascular risk, with someone with diabetes, it's less about the blood glucose. It's more about treating the blood pressure and the cholesterol and the weight loss and the exercise. And those things are all still very important. But what's really exciting about SGLT2 and GLP-1 agents is that they, in addition to lowering blood glucose, also seem to have some favorable cardiovascular effects. One thing about GLP-1s, maybe you could say something about, they're also used as weight loss medications in some patients, right?
Yeah, that's exactly right. So one of the potential benefits of the GLP-1 receptor agonist, right, since they induce satiety, a feeling of fullness, is that they can lead to weight loss, and in some cases, pretty substantial weight loss. And so many of the drugs that are available as GLP-1 receptor agonists for the treatment of diabetes also have another indication. They can also be used for weight loss. So that's been another, very important advantage of those medicines. And one of the factors that we often look at if we're sort of deciding between which therapy to use for a patient that is obese and has metabolic syndrome, we might reach for a GLP-1 receptor agonist both to treat their diabetes, but also for the weight loss effects, which would also be beneficial in terms of blood pressure and cholesterol and all the other things that you were just referring to. So you're absolutely right about that is one of the important advantages of the GLP-1 receptor agonists.
And to be fair, I think it's worth saying that SGLT2 agents also have been associated with a little bit of a reduction in weight. And that's significant because some of the older agents, including insulin, we don't like to tell it to our patients as much as we could, but they are associated with weight gain.
That's exactly right. So the SGLT2 inhibitors, because they have a kind of diuretic-like effect where they cause the loss of sodium and glucose and water in the urine, can have a modest, effect or reduction in weight. The weight loss that's seen with the GLP-1 receptor agonists is certainly of a larger magnitude, but you're quite right, Mike, that with both classes, you can see some weight loss. And I think that's important for the audience to hear.
And Nihar, what are some of the common names of these SGLT2 and GLP-1 agents? What would would patients recognize them as?
Yeah, so I think, for the SGLT2 inhibitors, you probably recognize names like dapagliflozin or empagliflozin. Jardiance, for example, is one that you might see, commercials for. And then similarly on the GLP-1 receptor agonist side, you might have things like liraglutide, exenatide, Bydureon. There are a number of these that are now available, and I think it's important to obviously talk to your healthcare provider and learn more about these different options that are available to you. But I'm sure you've probably seen either in lay press or certainly on television, different commercials and advertisements for these different therapies.
And one other distinction between them, the GLP-1s are often, not all of them, but many of them are injected, whereas the SGLT2s are taken orally as a pill.
That's exactly right, Mike. And I think that's another important consideration. Is exactly that there is one orally available GLP-1 receptor agonist, but you're quite right that most of them are administered subcutaneously. So it is an injection. And that's in contrast to the SGLT2 inhibitors, which are pills. And most of them, in fact, all of them, are just taken once a day, one pill once a day.
So Nihar, one thing I've really respected and appreciated in the work we've done together is how well you know the data. So can you tell us a little bit about what the evidence is about these newer agents and cardiovascular risk?
Yeah, I think there's certainly been a lot of literature. There have been a lot of studies, and I think that has really been important for providers and patients to make informed decisions about their healthcare of what is the right kind of management strategy for the individual patient that's in front of us. And so I think across all of those studies, if you kind of take a step back or maybe two steps back and say, what have we learned about SGLT2 inhibitors and GLP-1 receptor agonists? Let's maybe start with the SGLT2 inhibitors. That what we've learned is a couple of important points that for patients that have diabetes, starting an SGLT2 inhibitor probably reduces your risk of a kind of adverse cardiovascular event, a heart attack, a stroke, the need for a stent or an angioplasty procedure by around 15%. I think the estimate for the GLP-1 receptor agonist is probably very similar, about a 15% reduction in terms of heart attack, stroke, angioplasty or bypass surgery. And I think that's a very important advance in our management of diabetes. Again, we sort of referenced this before, that for so long, we were left with, yes, many different therapeutic options, but really none that had been shown to improve cardiovascular outcomes for patients. And in fact, Mike, I think you very rightfully made the point of, in fact, there are some that actually had concern for maybe increasing the risk of some of these cardiovascular events. So now we have two classes that, when administered to patients with diabetes, seem to actually reduce the risk of heart attack and stroke. So a very important finding. I think in terms of the numbers, very similar magnitude of benefit for the two different classes.
I just wanted to say a word about the 15% statistic. It may seem modest, a 15% reduction. Certainly compared to what we had before, that's a very significant advance, and compared to many other things we do in medicine. In addition, these agents, of course, also prevent the other complications of diabetes, eye disease, kidney disease, and so forth. So they have other benefits. But I also think that's another reminder why the lifestyle interventions are so important, that, the medications will modestly reduce your risk, but it's also important to eat healthy and exercise just because you're on these medications, because you really want to more significantly reduce the risk. Now, these medications were so encouraging in patients with diabetes that the drug companies and researchers began asking the question, could they work for other patients, maybe those with kidney disease or heart disease who don't have diabetes? And what have we learned about that?
Yeah, that's a really important question. And the history there is exactly right, that after so many encouraging trials and research studies in patients that have diabetes and all the benefits that were observed, people asked the question of, well, hey, if they're that good and they're that effective, what would happen if we gave them to patients without diabetes? Of course, these patients, have heart failure or kidney disease. And now we're learning that in those populations, patients that have heart failure or patients that have kidney disease, that the SGLT2 inhibitors are highly effective at reducing the risk of heart failure and heart failure hospitalizations in the first case, and then also preventing progression of kidney disease, including the need for dialysis with SGLT2 inhibitors amongst patients that have underlying kidney disease, whether that be from diabetes or from other causes. And so Mike, you're exactly right that I think we've gotten even additional information now, I would say especially about the SGLT2 inhibitors in patients that don't have diabetes, but have other important conditions that we think might be importantly treated with SGLT2 inhibitors, namely heart failure and kidney disease.
And Nihar, correct me if I'm wrong, but I think there was a study with an SGLT2 inhibitor that showed a reduction in heart failure in patients with a type of heart failure called diastolic heart failure, that there has never previously been a medication to show improvement in mortality in before.
Yeah, Mike, you're exactly right. There was a lot of excitement and enthusiasm when the drug empagliflozin or Jardiance was tested in patients that have exactly as you call, preserved ejection fraction heart failure or diastolic heart failure, a kind of heart failure for which we never had any evidence-based therapies. We saw, in fact, half of the patients that we would see in the hospital or in our office with heart failure have this kind of heart failure called, preserved ejection fraction or diastolic heart failure. And, besides treating their hypertension and trying to prevent blockages of the heart arteries, we never really had any dedicated therapies for their heart failure. And all of that changed with a clinical study called Emperor Preserved. And that really showed that if you used Jardiance or empagliflozin in these patients, you could actually substantially reduce the risk of winding up with a hospitalization for heart failure by about 25%.
So this podcast is called The Healthy Skeptic MD. And the reason is because, I try to not take everything you hear at face value and, think about what the potential concerns can be. I tend to be a late adopter with new medications because, I think history has taught us that a lot of times safety concerns arise over time. I am really starting to come around on these medications, but they are still new and we don't have as much safety data on them as some of the older agents. What makes you concerned, or what potential safety concerns are you worried could arise in the years ahead with these?
Yeah, Mike, I think your approach is probably one that I would also prescribe to myself, of just being, it's important to be skeptical. It's important to look at the data. It's also important to try and apply that data to the individual patients, that are in front of us. And yes, for all the enthusiasm and all the excitement that we have for these two different, drug classes and what they might mean for our patients with diabetes, I think there are some things that still give us some pause. So first, for the SGLT2 inhibitors, they can cause, volume depletion, lightheadedness, dizziness, things like that because of how they work. That's an important, consideration. There was an initial concern that they might be associated with the need for amputations. I think that we've seen enough additional reassuring data now to probably put us at ease in terms of that particular risk. And then you're always concerned, especially in the patients with diabetes, for having hypoglycemia or, actually precipitating diabetic ketoacidosis. Those things are very, very serious complications. Now, I should say for the audience that thankfully, at least in what we've seen in the clinical trials and the studies that have been done, and what we've seen now kind of in real world populations as these drugs have been adopted, is that the rates of those things are quite low. And so again, important to kind of talk through those things with your healthcare provider. But again, it's always important to be skeptical. It's important to inform yourself and also ask questions about, hey, what should I be looking out for? What do I need to be worried about? Similarly, kind of with the GLP-1s, they can be associated with GI intolerance, nausea, vomiting, and other kind of similar, primarily GI-related side effects. And then the one big other issue that we have to confront, and I think, Mike, you alluded to this at the very top of our time together, which is cost. These are new therapies. Yes, there's a lot of excitement. Yes, there's a lot of great data for them. But the cost is something that we have to confront head on. Cost is an important barrier to access for too many of our patients. And these drugs are both quite expensive. And we know that our patients are not just on one or two medicines, that many of our patients are on 3 or 4 or 5, different medicines, and that as those costs, continue to add up, as you go kind of month over month, too many of our patients, have challenges in terms of, financial difficulties and other challenges. And so I think we do have to be careful about making sure that, we're advocating for our patients, that we're trying to get, prices down for important, therapies. But that's an important consideration that we have to kind of, approach head on.
At the risk of putting you on the spot, do you know ballpark what the cost of these medications are?
Yeah, so the list price of the SGLT2 inhibitors is somewhere around $3,000 or $3,500. I think the GLP-1
per year.
Per year. The GLP-1s are pretty similar in terms of cost. We've actually done some studies looking at access and coverage of these drugs by different insurance plans. Most plans, of course, cover them. There is a co-payment, that is, of course, borne by the individual patient that can range from anywhere from, $10 or $20 a month up to $50 or $60 or $70 a month. And then for patients that have Medicare Part D, if they're in the donut hole, they will, of course, bear a larger portion of that cost. directly out of their pocket.
So Nihar, in addition to the safety issues, one key question I have in my mind is I really want to know how these medications stack up against each other, against some of the older agents. A lot of times the pharmaceutical companies, their primary purpose in funding research is to get their medication FDA authorized or approved. And that necessarily doesn't always take a head-to-head study. Sometimes there's simpler pathways to do it. And, so I think one question we really need to get is that comparative effectiveness research where what is the second line agent for diabetes after metformin?
Yeah, I couldn't agree with you more. And I think it's a place where either the manufacturers of these different drugs have to kind of come to the table, or the government has to sponsor the exact kind of research that you're talking about. How do we guide practitioners and individual patients to make informed decisions with the best evidence available? Yes, we've seen a lot of promising data for these agents, but how do we really do the head-to-head comparisons that practitioners need to know in order to then make evidence-based decisions for the patients that they're caring for? And so I think you're right that there is still a lot of evidence generation needs that we have in terms of guiding our clinical practice for patients with type 2 diabetes.
So that gets to my last question for you. Granted that we don't have all the evidence we'd want, but in the face of this, of what we do know, where is the role of SGLT2 and GLP-1 inhibitors, both in patients with a new diagnosis, for example, of diabetes, and then in also some of those patients with heart failure or kidney disease? Maybe if you could take each of those scenarios separately.
Yeah, I think, our own experience has been much more use of the SGLT2 inhibitors. They're orally available. They have very strong effects, beneficial effects on cardiovascular events, and have shown to be beneficial for patients with heart failure and with kidney disease. And so as a cardiologist and someone who sees many, many patients, obviously with those clinical conditions, I've gotten much more comfortable adopting the SGLT2 inhibitors into my own clinical practice. It's also been, important and refreshing to see that maybe what was, not so often done just 1 or 2 years ago. Now we see our trainees and our youngest, medical professionals actually using these therapies, getting comfortable with them, and I think hopefully seeing benefits and realizing benefits for the patients that we serve.
And for patients with heart failure, including diastolic heart failure, have you started to use them for that purpose as well in patients without diabetes?
Yeah, we've been using them for patients that have a weakened heart muscle or systolic heart failure for, a year and a half or maybe even 2 years now. And then we're just now starting to use them in patients with diastolic heart failure. The data for that, was released just, kind of at the middle end of last year, in August of last year. And so we've now just started to, really look at that data, take a hard look at that data, have some multidisciplinary meetings, within our health system, and are now starting to roll out our clinical protocols and pathways for the use of SGLT2 inhibitors for our patients with diastolic heart failure.
Well, in my primary care practice, and I don't tend to see as many severe cardiac situations as you have, I have certainly started to use SGLT2 inhibitors right after metformin. So metformin is still the first agent I use, and then SGLT2 inhibitors. And that's a big shift because until a year and a half ago, I was using glipizide and other older agents for diabetes. A very significant change. And I have used it in 1 or 2 patients with systolic heart failure and, not yet for diastolic heart failure, but I'm sure that opportunity will come soon. So certainly if you are someone who is on diabetes, has diabetes, has been on some of these medications, it may be worth asking your doctor if some of these newer agents are an option for you. And that also applies if you have heart failure and potentially kidney disease as well. So, Dr. Nihar Desai, I so appreciate your joining me today. You really explained a complex issue clearly in an area of medicine that's changing quickly. So I really appreciate your joining me today.
No, thank you again for having me. I really enjoyed the discussion and wish you all the very, very best.
And if you did find today's episode engaging, please do search and subscribe to the Healthy Skeptic MD wherever you listen to podcasts on YouTube and pass it along to others who might be interested. We'll pick it up again in a couple of weeks. Thanks again, Nihar.